Have you ever had that kind of nagging feeling in your chest, maybe your throat?
Hmm.
Like maybe it's heartburn that just hangs around after you eat, or a cough you can't shake, or even that weird sensation like something's kind of stuck.
Yeah, that globus is feeling sometimes.
Exactly. And the esophagus, that tube connecting everything, we don't really think about it much, do we? Until something feels wrong.
That's usually how it goes. Out of sight, out of mind.
So today we're really going to get into it, a deep dive into all things esophageal conditions. We're taking all the source material you sent over and trying to make sense of it all.
Turning that info stack into something useful.
Right, giving you a bit of a shortcut, hopefully, to understanding this pretty vital part of your body.
That's good. Where should we start?
Well, I was thinking, if the esophagus is like the main road to your stomach, sometimes you get these like universal warning lights flashing on the dashboard, right?
That's a great analogy, yeah.
So what do those lights actually mean? Let's maybe decode those common signals first. The ones that tell you something might be up.
Okay, yeah. That makes sense. So when something's off with the esophagus, there are usually three common symptoms that pop up across a lot of different conditions, kind of like those universal alarms you mentioned.
Mm-hmm.
First off, there's pain when you swallow. The medical term is odynophagia, and this isn't just like discomfort, it's actual pain going down.
Okay, pain. Got it.
Then there's dysphagia. That's difficulty swallowing. It can feel like food is getting stuck, or maybe it just doesn't go down smoothly, you know?
Right, like it's catching somewhere.
Exactly. And the third one is that retrosternal chest discomfort, basically pain or just an uncomfortable feeling right behind your breastbone.
Okay, so pain swallowing, difficulty swallowing, and chest discomfort.
Those are the big three. But, and this is important, while lots of issues can cause these, the way they show up, the nuances, that's what really helps us figure out what's actually going on.
So the devil's in the details, kind of.
Pretty much. Knowing there's a problem is step one, but figuring out what kind of problem requires looking closer.
Okay. And speaking of common problems, I guess we have to talk about GUR, right? Gastroesophageal reflux disease. Your sources say it's not just common, it's like the most frequent cause of esophagitis, that inflammation.
Oh, absolutely.
Oh,
It really is.
yeah.
GERD is essentially what happens when stomach contents reflux or flow back up into the esophagus, and that causes symptoms or sometimes even actual damage to the lining.
Okay.
And we kind of categorize it. Sometimes you have all the symptoms, the heartburn, the regurgitation. But when we look inside with a scope, the esophagus lining looks okay. That's non-erosive reflux disease.
Ah, okay.
Other times, the acid has caused visible irritation, erosions, sores. That's erosive esophagitis. And then there's a more significant potential complication called Barrett's esophagus, which we should definitely get into later.
Right, Barrett's. Okay. So thinking about prevention or management, if someone's listening and wondering, what can I actually do about this? What are the lifestyle things that usually make the biggest difference with GERD?
That's a really key question because when you look at the risk factors, a lot of them are lifestyle related. Probably the biggest modifiable ones are weight management,
Mhm.
especially if you're carrying extra weight around the middle. That abdominal pressure can push stomach contents up.
Makes sense.
Also, avoiding really large meals, not lying down right after you eat, giving yourself maybe 2-3 hours before bed to digest. That helps a lot.
Okay. So timing and portion size.
Definitely. And of course, quitting smoking is huge and cutting back on alcohol. Those help for so many reasons, including GERD.
Right.
And then there are food triggers. These can be really individual, but common ones are things like fatty foods, spicy foods, chocolate, peppermint, coffee, citrus juices, even carbonated drinks for some people.
Mhm.
So paying attention to what you eat and when symptoms flare up is important.
So it's kind of like detective work for your own body.
Exactly. And beyond lifestyle, other things play a role. A hiatal hernia is a big one. That's where part of the stomach pushes up through the diaphragm. We see that linked with GERD quite often.
Okay.
Certain medical conditions, like scleroderma, can affect esophageal muscles. Even just getting older, being over 50, increases risk. And yeah, medications too.
Ah, medications. Which ones are we talking about?
Well, there are some that can relax that valve at the bottom of the esophagus, the LES. Things like certain calcium channel blockers for blood pressure, some asthma meds like beta agonists, anticholinergics, even things like diazepam or hormones like estrogen and progesterone.
Wow. Okay.
And then there are others that can directly irritate the lining, like bisphosphonates for osteoporosis, aspirin, NSAIDs, common pain relievers, some antibiotics like
Mhm.
tetracycline, or even potassium and iron supplements.
That's a pretty broad list, so it's worth checking your meds if you have reflux.
Definitely worth a conversation with your doctor.
Hmm.
Because fundamentally, the issue in GERD often boils down to that lower esophageal sphincter, the LES. It's this muscular ring acting like a valve.
Right, the one-way valve.
Exactly. It's meant to keep stomach acid down. But if it's weakened, or if it just relaxes when shouldn't we call those transient LES relaxations, then
Uh,
acid can splash back up. That's the core mechanical problem,
okay.
often.
So when that happens, what are the absolute classic telltale symptoms people usually report?
Right, the classic ones. The absolute hallmark is heartburn or pyrosis,
Yeah.
that burning feeling behind the breastbone. Often hits maybe 30 to 60 minutes after eating.
Mm-hmm.
It tends to get worse if you lie down or bend over,
Mm-hmm.
and sometimes the antacids give some relief.
Yeah.
Belching can come along with it, too.
Okay, heartburn, that's the big one.
And the other really typical one is regurgitation. That's when you get that sour or bitter taste in your mouth, like
Yeah.
the acid or stomach contents are actually coming back up.
Ugh, yeah, not pleasant. So those are the signals we often expect. But you mentioned the body can be tricky. Are there other ways GERD might show up that people wouldn't immediately think, oh, this is acid reflux?
Oh, absolutely. This is where it gets really interesting because GERD definitely doesn't always stick to the expected script.
Like what?
Well, for instance, it can cause chest pain that
Mhm.
feels so much like heart pain, like angina.
Really?
Yeah. It's actually the most common reason for non-cardiac chest pain after someone's had a full heart workup and it comes back clear.
Wow. Okay, that's important to know.
Definitely. Then you have what we call extraesophageal symptoms, meaning outside the esophagus. This could be a chronic cough that just won't go away, or maybe unexplained wheezing. Hoarseness is another one, from acid irritating the vocal cords. It can even make existing asthma worse.
A cough from reflux.
Yes, quite common. And then there's something called water brash, the sudden rush of saliva into your mouth.
Yeah.
It's almost like your body's trying to neutralize or wash away the acid.
Huh. Never heard of that one.
And that feeling of a lump in your throat, that persistent sensation, something stuck there, globus sensation, that can be GERD too, surprisingly.
Wow. Okay. So it can really manifest in a lot of different ways. It really makes you think about how our body signals things. So, given all that, when should someone be thinking, okay, this isn't just simple heartburn, I need to get this checked out now? What are those serious red flags?
That's a critical point. There are specific alarm features that really signal something more serious might be happening. Could be a complication of the GERD or even, something worse like a gastrointestinal malignancy.
Okay. Like what specifically?
If you develop new difficulty swallowing, that dysphagia we talked about, or pain when swallowing, the odonophagia, that's a big one. Also, unexplained weight loss or losing your appetite.
Right.
Any signs of bleeding are major alarms. So that could be blood in your vomit or black, tarry stools, or even just finding occult blood in a stool test. Persistent vomiting is another
Yeah.
flag.
Bleeding, swallowing issues, weight loss.
Also finding signs of iron deficiency anemia without a clear reason. And age is a factor too. If you're over 60 and these symptoms are new for you, that warrants investigation. Or if you have a first-degree relative like a parent or sibling with a history of GI cancer.
Got it. So any of those, and it's time for a doctor visit, probably leading to an endoscopy.
Absolutely. If any of those alarm features are present, an upper endoscopy is definitely the next step. Because those signs often point towards the main complications of long-term untreated GERD.
Which are?
Well, besides the esophagitis itself, the inflammation chronic acid exposure can cause the esophagus to narrow, forming what's called a stricture. That makes swallowing difficult.
Okay, a narrowing.
Then there's Barrett's esophagus, which we mentioned, that change in the cell lining. And the most serious is esophageal adenocarcinoma, a type of cancer that can develop from Barrett's.
That really highlights why getting GERD managed is so important, not just for comfort, but for long-term health.
Exactly. It's not always just benign heartburn.
So how do doctors typically approach diagnosing GERD, and then what are the main treatment paths?
Okay, so for someone with classic GERD symptoms, heartburn, regurgitation, and no alarm features, doctors can often make a presumptive diagnosis just based on the symptoms.
Just clinically.
Yeah, and they might start treatment empirically, usually with a trial of a medication called a proton pump inhibitor, or PPI. These are very effective acid blockers. In this scenario, an upper endoscopy isn't usually needed right off the bat.
Okay. So try the meds first if it seems straightforward.
Right. But if those alarm features are present, or if the symptoms don't get better with the PPI trial, or if we suspect a complication like a stricture or Barrett's, then upper endoscopy becomes the first-line diagnostic test. It lets us see what's going on and take biopsies if needed.
Makes sense. Are there other tests sometimes?
Yeah, for more complex or persistent cases, we might use esophageal manometry. That measures the pressure and function of the esophageal muscles, including that LES valve.
To check the valve strength.
Exactly. And the other main one is 24-hour ambulatory pH monitoring. This is often considered the gold standard, especially if the diagnosis is uncertain or symptoms aren't responding. You wear a small probe that measures acid levels in your esophagus over a full day.
Wow. Okay. Very thorough. And management-wise?
Management usually follows a kind of step-up approach. The absolute cornerstone for everyone is lifestyle and dietary changes. We talked about those: avoiding trigger foods, weight loss if needed, not eating late, elevating the head of the bed for nighttime symptoms, quitting smoking.
Right, the foundations.
For mild, maybe intermittent symptoms, you might start with just those lifestyle changes, plus maybe using over-the-counter antacids or low-dose H2 blockers like famotidine, just as needed for relief.
Okay.
But for moderate to severe GERD, or symptoms that are happening frequently, the typical first step is an 8-week trial of a standard dose PPI once a day, always in addition to those lifestyle modifications.
Got it. PPIs are the main medical therapy then.
They are generally the most effective for controlling acid and healing esophagitis, yes.
You mentioned Barrett's esophagus earlier as a consequence of chronic GERD. You said it involves cell changes. Can you unpack that a bit more? Why is that specific condition such a big deal?
Yeah, Barrett's is really important to understand. It's a direct result of that chronic acid baiting the lower esophagus. What happens is the normal lining, which is made of flat, squamous cells, gets damaged and starts to heal differently.
How so?
It gets replaced by cells that look more like the lining of your stomach or intestine. These are columnar cells. This change, this replacement, is called metaplasia.
Okay, metaplasia. Why is that bad?
Because those metaplastic columnar cells are considered precancerous. They have an increased risk of eventually turning into esophageal adenocarcinoma, which is a serious type of cancer.
Yeah.
So Barrett's itself isn't cancer, but it's a known pathway towards it.
Okay. That's the critical link. So how is it found and managed?
It's always diagnosed via upper endoscopy with biopsies. You have to actually see those columnar cells under the microscope to confirm it. Management then involves two main things: aggressive acid control, usually with long-term PPIs, to try and prevent further damage,
Right.
and regular surveillance endoscopies. This means having scopes done periodically, maybe every 3 to 5 years if it's just metaplasia, but more often if there are signs of dysplasia, which means the cells look even more abnormal. If high-grade dysplasia is found, we often intervene more actively, maybe with procedures to remove or ablate that abnormal tissue.
So it requires ongoing monitoring.
Definitely. It's all about catching any progression early.
Okay, so we've covered reflux pretty thoroughly, but what about when bugs are the problem? Your sources mentioned infections can also cause esophagitis.
They certainly can. It's not as common as GERD overall, but definitely important, especially in certain groups of people. The main culprits are a type of yeast, candida, and 2 viruses: herpes simplex virus, HSV, and cytomegalovirus, CMV.
Candida first, like thrush.
Exactly. Candidiasis, usually caused by Candida albicans, is actually the most common cause of infectious esophagitis.
Right.
Now, Candida is part of our normal body flora, lives harmlessly in most of us,
Right.
but it becomes a problem. It becomes pathogenic when the immune system's weakened. So we see it a lot in people with advanced HIV, especially with low CD4 counts, organ transplant recipients, people on chemotherapy, or long-term high-dose steroids.
So mainly immunocompromised folks.
Mostly.
Yeah.
But interestingly, you can sometimes see it in people who are otherwise healthy, but maybe using inhaled corticosteroids for asthma, or even people on long-term PPIs. The acid suppression might change the environment just enough.
Huh. Okay. And what does it look like?
Often the only outward sign might be associated thrush, those white patches in the mouth or throat.
Yeah.
When we look inside the esophagus with a scope, we typically see these characteristic white or yellowish plaque-like lesions stuck to the lining.
Like cottage cheese, almost.
Kind of, yeah. Diagnosis is confirmed with biopsy showing the yeast. But in someone who is known to be immunosuppressed and has visible thrush, doctors might actually start empiric treatment with an oral antifungal, usually fluconazole, even before the scope results are back.
Just treat based on suspicion.
In that specific context, yes, it's often done. Fluconazole is the first-line treatment, usually for 14 to 21 days. Topical antifungals used for oral thrush don't work for esophageal candidiasis.
Got it. Okay, what about the viruses, HSV?
Right. Herpes simplex virus esophagitis, usually HSV type 1, the same one that causes cold sores. This is the second most common infectious cause,
Oh.
again, predominantly seen in immunocompromised patients. But it can occur in healthy people too. In healthy hosts, it's often self-limited, meaning it goes away on its own.
And how does it happen?
It's often thought to be a reactivation of the virus that's been dormant, maybe traveling down the vagus nerve to the esophagus, or sometimes spreading directly from an oral herpes infection.
Okay, and the look. You mentioned clues in the names before.
Yeah, so for HSV, maybe think S for small and submarine or deep. Endoscopy typically shows multiple small, quite deep ulcers. They often look well circumscribed, almost like they've been punched out with a hole punch, or sometimes described as volcano-like.
Punched out, okay.
You might also see coexisting cold sores, herpes labialis. The biopsy is key here too. It shows characteristic changes in the cells called Cowdrey A inclusion bodies and multinucleated giant cells.
And treatment.
For immunosuppressed patients, the antiviral medication acyclovir is first line. In immunocompetent people, as I said, it often resolves spontaneously, but acyclovir can speed up the healing process if needed.
Right. And the last bug, CMV.
Cytomegalovirus, or CMV. It's actually a type of herpes virus too, HHV5. This is the third most common infectious cause. And CMV is incredibly common in the population, like 60–70% of adults in the U.S. have been exposed, almost everyone in developing countries.
Wow, really?
Yeah. But again, it mostly causes disease in people with severely weakened immune systems. It's the most common viral opportunistic infection in people with AIDS, especially when CD4 counts drop below 50. Also seen in transplant patients, chemo, high-dose steroids, very occasionally in healthy people too.
And the clue for CMV, you said M4.
M4 mega, think large.
Yeah.
Endoscopy classically reveals large, sometimes quite long, superficial or shallow ulcers. They might be described as serpiginous, meaning sort of snake-like or wavy.
Large and shallow. Okay, different from the small, deep HSV ones.
Exactly. And the biopsy finding is also classic. These large cells with characteristic inclusions that look like an owl's eye.
Owl's eye inclusions, got it. Anything else with CMV?
Yes, because CMV can affect other organs, especially the eyes, causing retinitis. An ophthalmologic exam is usually recommended for anyone diagnosed with CMV esophagitis.
Good point. And treatment.
Treatment usually requires intravenous antiviral medication, with Ganciclovir being the first-line choice.
Okay, that's a good rundown of the infectious causes. Seems the immune status is a really big factor there.
It really is.
So just to round things out, are there any other sort of distinct esophageal conditions we should quickly touch on from the sources?
Yeah, a couple more worth mentioning briefly. One is caustic esophagitis. This is really serious, caused by swallowing corrosive substances, things like drain cleaner, lye, strong acids, bleach.
Oof. Yeah. That sounds bad.
It is. Symptoms are usually immediate and severe. Intense pain swallowing, difficulty swallowing, maybe vomiting blood. The crucial thing here is management. It's supportive care only. You should never induce vomiting, never try to give neutralizing agents like milk or vinegar, and steroids are not helpful. Those things can actually make the injury worse.
Right. Just get emergency help.
Absolutely. Then there's hiatal hernia, which we touched on as a GERD risk factor.
Yeah.
Just to recap, that's when part of the stomach pushes up through the diaphragm opening.
The two types, right.
Yeah, the sliding type 1 is most common, maybe 95%. The top of the stomach and the GE junction slide up, often associated with more reflux.
Okay.
The other is paraesophageal type 2. Here, the GE junction stays put, but part of the stomach, usually the fundus, bulges up alongside the esophagus. These might not cause symptoms, but they carry a risk of complications like twisting or strangulation, so they sometimes require surgical repair even if asymptomatic.
Got it. Sliding and paraesophageal.
And one last one, mainly seen in newborns, is esophageal atresia. This is a birth defect where a part of the esophagus just didn't form properly. It's either completely missing or closed off.
Oh, wow. How's that picked up?
Usually right after birth. The baby will have lots of oral secretions, choking, can't feed properly, might have trouble breathing. The definitive diagnostic clue is often the inability to pass a feeding tube down into the stomach. It just stops. This requires surgery pretty quickly.
Okay. So quite a spectrum there.
Yeah.
Now, bringing it all together. With all these conditions, GERD, infections, structural issues, and the symptoms often overlapping, like you said, pain, difficulty swallowing, how do doctors reliably figure out what's actually going on? It seems like the diagnostic tools must be key.
They absolutely are. And the workhorse, the main tool for sorting most of these out, especially if there are any alarm features or if symptoms persist or we suspect an infection, is the upper endoscopy with biopsy.
The scoop.
Exactly.
Yeah.
It lets us directly look at the lining of the esophagus. We can see those white plaques of Candida, or the small punched-out ulcers of HSV, or the big shallow ones of CMV. We can see inflammation, erosion, strictures, Barrett's changes.
Visual confirmation.
Right. And crucially, we can take biopsies, small tissue samples to look at under the microscope.
Hmm.
That's how we confirm infections, by seeing the yeast or the viral inclusion bodies, or confirm Barrett's by seeing the metaplastic cells, or check for dysplasia or even cancer cells.
So the scope and the biopsy are really central.
For most definitive diagnoses, yes.
Yeah.
But it's worth saying again, for that uncomplicated classic GERD presentation without alarm signs, we often don't need the scope right away. We can diagnose it clinically and treat empirically first.
Right, reserving the scope for specific indication.
Exactly. And those other tests, the manometry and the 24-hour pH monitoring, they have their specific roles too, mostly for difficult GERD cases or when the diagnosis isn't clear after initial steps.
Okay, that clarifies the diagnostic approach really well. Well, we've definitely taken a real deep dive today, covered a lot of ground from, the incredibly common GERD that affects so many people, right through to these more specific infectious causes and even structural issues like hernias and atresia. It's quite a spectrum.
It really is.
Yeah.
And I think if there's one main takeaway from looking at all this material, it's that while many of these conditions share those initial warning signs, the pain, the swallowing trouble, the chest discomfort, really understanding the specifics matters. The particular characteristics of the symptoms, the risk factors involved, and especially paying attention to those alarm features we talked about.
Mm-hmm.
That's what's absolutely key for figuring out what might be going on, and critically, knowing when it's time to stop self-treating heartburn and actually seek medical advice.
Yeah, that really comes through. This whole discussion just makes you think, doesn't it? How symptoms that seem so similar on the surface can point to such wildly different things happening underneath, and how important it is to, well, listen to your body, but also get professional advice, especially if any of those alarm bells are ringing. So for you listening, what stands out the most after hearing all this? How these different conditions show up, maybe? And perhaps, is there one thing you might think about or do differently now, being a bit more informed about your esophagus?